mission at NCPD is to manage the population. Our mission at NCPD is to manage the population. Oh, our mission at NCPD is to manage the population. Our mission at NCPD is to manage the population. Oh, our vision at NCPD is to improve the lives of Kenyans. Our vision at NCPD is to improve the lives of Kenyans. Oh, our vision at NCPD is to improve the lives of Kenyans. Our vision at NCPD is to improve the lives of Kenyans. Kenya to develop, we must run a population. NCPD has provided validation and guidance. NCPD is committed to manage the population, providing education and improve the lives of Kenyans. We are calling on Kenyans to Pangeni Familia. We are calling on Kenyans to Pangeni Familia. We are calling on Kenyans to Pangeni Familia. Calling on Kenyans to Pangeni Familia. All join NCPD and support population programs. Join NCPD and support population programs. Let's all join NCPD and support population programs. Let's all join NCPD and support population programs. Attainment of targets from Vision 2030 will help in transforming our country, Kenya. Attainment of targets from Vision 2030 will help in transforming our country, Kenya. Learning our population will help bring development. Our economy will grow if we all plan our families. NCPD has provided quarantine and guidance. Let us support the government to manage population. Our mission at NCPD is to manage the population. Our mission at NCPD is to manage the population. Oh, our mission at NCPD is to manage the population. Our mission at NCPD is to manage the population. Oh, our vision at NCPD is to improve the lives of Kenyans. Vision at NCPD is to improve the lives of Kenyans. Oh, our vision at NCPD is to improve the lives of Kenyans.
So, dear delegates, welcome back. We're trying to switch from our webinar to the Zoom, and this is the Zoom we're going to use for now the next 3 days. Here we are admitting everybody here, but then once we get quite full of people, we transition and we go into our thematic areas. So what we have not yet started opening for the thematic areas, so we want to bring everybody here conference room. We'll be hosting the mobility and mortality, the sub-theme childhood mobility and mortality, which is chaired by Dr. James Nika. The other panelists will transfer you. If there is a click, that there's a bar that's going to come up there.
We'll open it.
Once we open the breakout sessions, you click the area that you want to join, the session that you want to join, and it will automatically take you to your panel. The panelists also can do that. So we are going to do it in the next. How many minutes?
No.
Now we can do right now. We're going to do right now. So there are going to be 5 themes, plus this one 5, yeah. So we're going to have the first theme, sub-theme is going to be population size and growth. Another sub-theme is going to be adolescent and fertility. The other one is going to be child mobility and mortality. And we're going to have mobility and internal migration, population and environment. The first theme is chaired by Dr. Ann Kasakala. Presenters is Dr. Peter Nyakwara, Mr. Michael Musyoka, and Ben Jaradi. So that team will go to the link where we have population size, growth, and age. And anyone who wants to join them or who have already selected to join will automatically either put you there, or you can right now click and join that session.
After the instruction.
Okay, after I finish the instruction, that's what I'm told. Now the second thing, which is going to be adolescent and fertility, which is chaired by Dr. Isaac Bashir. Presenters are Professor Ochieno Alfred, Professor Ruth Nduati, Mrs. Pamela Duso, and Dr. Kiara Ann. So this team will be in the fertility, sub-theme adolescent and fertility. So that also will appear, and then you will also click that in and you'll go there. The other theme is going to be child mobility and mortality, Dr. James Nika. That one you don't need to click anything. You will remain here, and any other person who has not chosen or selected any thematic area can still remain in this. And this is the one which is going to act as our plenary session after we even finish the thematic areas. The other one is going to be a sub-theme of the mobility and internal migration towards orderly mobility and productive economy. And the chair is going to be Engineer Mairura Omwenga. And then presenters is Ms. Mary Kalerwa, Dr. Lutechu Kulaka, and Engineer Francis Gitao. That one you will click, and then you will get your panelist, and also you get there for discussion. The other one, which is chaired by Dr. Charles Lange, is the presenters are John Kioko Musingi, James Ochieno Kaoga, and Professor Soste Chiota. So that one again, you can click and you'll join that panelist. So I think from now we can start. I think we have more than how many participants now? 100?
116.
116? So at least the panelists, you don't have a choice. You just need to go to your respective session, and that's where you have the panelists plus the chair. So let's start now. This will, after that, we will have, once you join that, these sessions will take 9 minutes.
Yeah, we've started.
Yeah, we have started. So continue joining, please. We want to see the numbers we have here reducing so that they're going to the thematic areas. Automatically, you will come back to this plenary, and this is where we're going to close. Yeah.
Where are we joining?
You choose one of the 4 or remain in plenary.
So there are 4 areas that you can select. So you can select either population size and growth. You can join that one. They're just there on the screen.
Yeah.
When you look at your screen, you'll see it. You just click it, it will take you to your sessions. If you have not selected and you don't want to choose any other session, but you can still remain the plenary, where we're going to discuss about childhood mobility and mortality, where it's going to be done by Dr. Mikal, with Professor with Dr. Wangari Nganga, Laura Bonerelli, and Nancy Gituku. So that's another team that if you have not selected any selection, you can stay here. But we want the panelists, also they have no choice, they have to go to their respective session. Is that clear?
Excuse me.
I have no themes on the screen.
There are no themes on the screen.
Refresh.
Just refresh, that's what I'm told. Please refresh.
I think they have to check under breakout rooms at the bottom.
Yes.
Yeah.
The phone is at the top.
If they are using the phone, is at the top. If it is computer,
I'm told if you're using the phone, it's at the top. Yeah. This is technology, virtual conferences. Dr. Anna, you okay there?
Which Dr. Anjiru will do. You
Anjiru
can
is
also assign her.
Yeah. Chair, population size and growth. Can you
Yes,
listen?
she's there. I can see her. She's in the group already.
In the
She's
group,
number
yeah.
one after.
Okay.
Mm.
Okay. Just assign that please. Yeah. Me and my meeting aside. So this is going to be 90 minutes, but we can just give ourselves another 5, 6, another 10 minutes. Then we can start our sessions. Session chairs, I think, can take over from there. You'll come back here at 1:45.
Morning. Can I assume that everybody here now is on our theme of child mobility? Hello?
Yes. Yes.
Not really, Prof. We are all here from different sub-themes.
You are okay. So okay.
I am
Then-
chairing the sub-fertility team, and then we're in the same boat with you. Let's wait for them to sort us.
Prof, Daktari, let us give them a few minutes to relocate.
Yeah, that's what I'm saying. If they don't relocate,
We will continue. Yes.
Mm.
So, Mheshimiwa, Dr. Nikal and the team, and Dr. Bashir, I think that's what you do. Click on your session. If you are using your phone, you can just click up on the top there on your phone, and you will get the breakup sessions. There you will see the team on where you are chairing on adolescent fertility, and then you look in there, you will find your team. But you can do it from here. I think they're doing that. Yeah. Dr. Bashir, are you still there? So the others also can do the same.
I think Dr. Bashir has already joined. That's
That's
why
it,
yeah.
So we okay?
Yeah, we'll continue.
Yeah, you're joining us.
These things are drag as they take over.
So you see, population we are 16, adolescents 1, 2, so it's populating, and the main one is decreasing. That's it.
And then someone manage the chat.
Sorry?
Someone from your team.
Yes.
The chat.
Chats.
The chat.
Get somebody. Who is inside? No, I'm saying, tell me who from LCD, because it changes. So that yes.
From 1. If 90 minutes from 1, it's up to 2:30. Yeah, what one day we say. Can we start?
Don't forget to record.
Yes.
We can start.
Mondela,
Yes.
please manage Dr.
Okay.
Yes, Dr. Nikal, please, over to you. Take over.
I can.
Thank you.
Okay, thank you very much. We are on the 3.1, childhood morbidity and mortality, and welcome everybody on this session. And we have our presenters. As you know, we have Dr. Ancient Kituku from Machakos, who will be giving childhood mortality, morbidity and mortality in Kenya, Dr. Wangari Ng'ang'a. Then we were expecting somebody from Unicef. I don't know whether we have information, and Dr. Laura. So although I've mentioned their names, I would like them to introduce themselves so that we are aware they are here. So, introduction, Dr. Kituku.
Good afternoon, everyone.
Yes.
Thank you.
Good afternoon.
I'm Dr. Adolescent Kituku.
What happened?
Someone is speaking. Yeah, I'm Dr.
What happened? We were sent back to the main room from the breakaway. What has gone on wrong?
Well, those who are with us, can we proceed, Dr. Kituku?
Yes, thank you, Dr. Nikal. I'm
Yes.
Dr. Adolescent Kituku, but most
Yes.
people call me ancient. I don't mind. I'm the elder CC from Machakos County. Thank you.
Welcome, Dr. Wangari. Is Dr. Wangari Nganga with us?
I'm here.
Yes, please just introduce
can you hear me?
yourself. Yes,
Very
we
good.
can hear you.
My name is Dr. Wangari Nganga. I work in the Presidential Policy and Strategy Unit as a Senior Health Advisor. Very honored to be with you all this afternoon. Thank you.
Thank you. And the representative from Unicef.
Mr. Chair, colleagues, Dr. Yaron Wallman from Unicef, Chief of Health. Very pleased to be here with you this afternoon. Thank you.
Thank you, Mr. Wallman. And Laura?
Good afternoon, everyone. My name is Dr. Laura Bonareri. I head Neonatal and Child Health Division at the Ministry of Health, Kenya. Very happy to be with you this afternoon.
Thank you very much, all the panelists, for being here with us in time. And we have taken up much time. Let me also welcome everybody who have decided to be with us. You are welcome, and we'll take questions. We'll try to be fast so that we have more time for the plenary. We know what we are dealing with is the issue of childhood morbidity and mortality. And as you know, in this country, we actually, in the last 5 to 10 years, have had pretty good progress in childhood mortality in particular. Even morbidity has gone down a bit. So I think we are here to share our experiences from various parts of the country and to see what is really going on. We'll particularly be looking at stunting, which I think will be extremely important for us. And then more important from Dr. Raola will be the policies, guidelines, and programs and intervention for addressing the deaths, and so that we get things just better. Maybe that will lead to better development and child development and better for the country's economy. With that, I think we'll go ahead and start our presentation, and I'll call Dr. Adolescent Kituku to start us off. Daktari, welcome.
Thank you, Daktari. I hope, Ken, you are sharing the presentation for us as agreed. Ken Lwaki.
Ken, yeah, we are expecting, Dr. Kituku, expecting that we shall have presentation shared. Yes, yes. I can see we're getting on the screen.
Yes.
Okay.
Yeah. Yes.
Daktari, is that where you want us to start?
Yes, you can give the full view. Just 10 slides so that we can move faster. Yes, so basically, welcome everyone. I'm presenting on the childhood morbidity and mortality, more or less in Kenya, with just a slight touch on Machakos County. Next slide, please.
Dr. Lwaki, Mr. Lwaki, Dr. Lwaki, next slide. Can we have the next slide, please? Yes, there you are.
Yeah, so there are some key childhood mortality terms which most of us are aware of. There is a neonatal mortality rate. Each one of them basically expresses as a number out of 1,000 live births. And the neonatal mortality is basically probability of dying within the first month of life. Infant mortality rate. Infant mortality again expresses a probability of dying before the first birthday. Child mortality, probability of dying between the first and the fifth birthdays. Under 5 mortality, probability of dying before the fifth birthday. As I've said, all expresses rates per 1,000 live births. Next slide, please. As we get the next slide, basically, health is now guided by the Sustainable Development Goals, all the 17 Sustainable Development Goals, but more specifically SDG 3, which deals with good health and well-being. And when it comes to the well-being of children, is specifically when the preventable deaths of newborns and children under 5 years of age, to reduce the neonatal mortality to at least, at most 12 per 1,000 live births, and under 5 mortality to at most 25 per 1,000 live births. Again, the other goal is to end the epidemic of AIDS, tuberculosis, malaria, neglected tropical diseases, waterborne diseases, and other communicable diseases. Also aiming to achieve a universal health coverage, which Kenya MAP is rolling out in all the counties, which includes financial risk protection, access to quality essential health care services, and access to safe, effective, and affordable essential medicines and vaccines for all, and substantially increase health financing and the recruitment of development, training, and retention of the health workforce in developing countries. Next slide. As Dr. Nyikala said, we've seen a significant reduction in the Kenya child mortality rate. And if we check this graph all the way from 1960, where our childhood mortality rate was at around 198 per 1,000 births, to the current last year, which was around 43.2 per 1,000 live births, which is a good development. But as you've seen from our SDG goals, we are supposed to be at around 25 per 1,000 live births. Next slide. And when you look generally at the causes of childhood morbidity and mortality, we notice that when it comes to childhood mortality, 41% of those childhood mortalities occur in the neonatal period, basically within the first month. And then the rest between the second month to the fifth birthday. And the commonest, some of the commonest causes are preterm, babies who are born preterm, pneumonia, birth asphyxia, sepsis, congenital malformations, diarrheal diseases, injuries, malaria, AIDS, meningitis, and other non-communicable.
Hello? Hello? Hello?
Yes, I can hear you. Someone muted everyone.
Okay, that's fine. Go on, Dr.
Yeah. Yes. So when it comes, you can go to the next slide. When it comes to Machakos County, we are seeing that the causes, the most common, the top 10 cause of childhood morbidity. The most common is upper respiratory tract infections at 63.9%, followed by skin diseases at 16.2%, ear infections at 4.6%, eye infections 3.4%, diarrheal diseases 3.4%, intestinal worms 2.9%, pneumonia at 1.9%, burns at 1.9%, urinary tract infections at 1.3%, and then other chronic lung diseases, including asthma and so on, at 0.5%. Of course, we know that across the country, there are counties whereby you find malaria is one of the commonest childhood causes of morbidity. Next slide. And yeah, basically when we analyze the causes of childhood morbidity and mortality, we realize that there are three main causes of newborn deaths. And these three main causes actually have some effective and feasible interventions. One of those causes is preterm births, whereby if we manage our antenatal care very well, and those mothers who go into preterm labor are given the antenatal corticosteroids, and the preterm labor is managed well, then you can be able to manage these preterm babies to be able to develop well and even achieve milestones. Again, good neonatal care, including essential newborn care and the kangaroo mother care. Then for birth complications, this can be prevented by ensuring that we increase the percentage of skilled birth attendants. At Machakos, now we are at 80% of all deliveries being conducted by skilled birth attendants, which is still low. We need to be hitting almost 100%. Then again, ensuring that there's care, including essential newborn care, and training our healthcare providers on a newborn and neonatal resuscitation. Then for neonatal infections, this can be prevented, again, by ensuring that there's essential newborn care, and including breastfeeding, exclusively probably for 6 months, use of chlorhexidine where applicable, and also on a case management of neonatal sepsis with the antibiotics. Next slide. And then there are some indicators which we can be able to use as a country to see how we are progressing in decreasing childhood morbidity and mortality. One of those indicators is the maternal mortality ratio, because again, we can't detach the mother from the newborns. And that's a very good indicator which should be improved across the country. Again, the issue of still birth rates and also neonatal mortality rate as an indicator. Then to be able to see the on coverage, care for mothers and newborns, increasing and improving skilled birth attendants, ensuring that there's early postnatal care for mothers and babies, exclusive breastfeeding for 6 months. Then where there are complications, again, ensuring that there's coverage, including antenatal corticosteroid use, newborn resuscitation training for healthcare workers, encouraging kangaroo mother care, especially for preterm babies, and ensuring that there is proper feeding support for the same, and the treatment of neonatal sepsis. There is also an area where we really need to improve on basically birth registration, where we know that there are quite a number of children who die in the community. And the capture of these statistics, vital statistics, is not well captured, and that should be improved to ensure that it is well captured so that we can learn from it and intervene. Again, every mother and every newborn, we need to have some quality initiatives to care for small and sick babies. Next slide. Again, we need to appreciate that behind every statistic, there's a story. When we are talking about now our childhood mortality rate being at 43.2 per 1,000 live births, there are stories. Those are real people. They are not just statistics. And I just picked a few comments from within and without, where Douglas from the USF said that we held our daughter in our arms, we shed our tears, said goodbyes, and went home to tell our little boy that he wouldn't have a sister. This gentleman from Lebanon, I felt devastated watching my newborn fight for his life, yet our beautiful baby, Karim, with the help of his dedicated medical support team, continued to fight and survive. Then we have a caption from Machakos County, one of our 2 hospitals with the antenatal newborn units. This mother, Agnes' mother, also said that born too early, weighing less than a packet of unga at only 800 grams. Agnes survived at Kangundo Level 4 Hospital Newborn Unit in Machakos County, and now is 7 years old with a good developmental milestones. Next slide. And probably this is a vision we need to have for every newborn, where we should strive to have a world in which there are no preventable deaths of newborns or stillbirths, where every pregnancy is wanted, where every birth is celebrated, and where women, babies, and children thrive and they reach their full potential. Next slide. And probably, this is the last slide.
Doctor, you have 2 minutes.
Yes, thank you. Actually, this is the last slide. So reducing childhood morbidity and mortality, this should be our guiding principles, where at the country and the county leadership, we should ensure that there's good governance, community participation, and partner alignment. Then we need to integrate service delivery, continuum of care, and program coordination. And we need to have innovative interventions, delivery approaches, and also technologies. Then we should also be guided by the human rights. As we know, health is a right, where then we should run it with the principles and standards. There should be accountability, transparency, and also proper oversight. And lastly, there should be equity, which we can achieve through the basically rolling out of universal health coverage to ensure that we close the equity gap. Next slide, which is basically the last one. So I'm thanking everyone and ready for any input. Thank you.
Okay, thank you, Dr. We've got for the session. It has been very clear. We really appreciate somebody like me. I saw the data, the statistics improve. Now, it has brought us all, if you want to reduce infant mortality, to look at neonatal care. I think that's the message that comes here, all aspects of neonatal care. I think we'll have questions at the end, so those who wish to make comments and ask questions, please take notes for each panelist. Then we will come at the end of it when we have the plenary, when we'll raise all the issues. Therefore, we'll move to the next presentation, Dr. Wangari Ng'ang'a, Stunting in Children and its Effects on Human Capital. I think that's very important. We want children to survive, be well-nourished, develop well, and be productive. And that's where we are. Dr.
Thank you, Mheshimiwa. Thank you very much. So I'll start by saying that I noticed there are very many Samuel Lubangas, and I am one of them, but my name is Dr. Wangari Ng'ang'a. I think on the screen it says I am Samuel Lubanga, and I feel like there are 10. I think IT.
Okay, we'll accept in knowing that you are actually Wangari.
So please accept that I am an alias for today. Thank you for the slide. Can we move to full presentation mode and go ahead and start? Next, yes. Next slide, please. So this slide, very wordy, just captures a few things that I thought were important to share in the context of what we are discussing, human capital and the intersection with stunting in specific. I talk of malnutrition, of course, which means both over and underweight, but I'll be specific in stunting. I think you heard in the president's speech read by the Honorable CS today that our score, the Kenya Human Capital Index score is 0.55. It's a score up to a scale of 1, which basically means our children by the age of 18 are only about 50% as productive as they would have been had we made the right investments during their journey. And so these investments spanning all the way from conception to adulthood comes this critical age we call the 1,000 days or the under 5, which is where we are seeing stunting. And taking a reflection on why this particular time period is important, within the first 5 years, 90% of all brain development occurs. So, the window closes really fast. It doesn't matter if you're doing the school feeding program when the child is in class 3 at 9 years, the window is gone. And despite great progress over the years, I think our last demographic health survey of 2009, stunting was at 35%. The 2014 demographic surveys at 26%. There's one ongoing right now. I think the data collection tools are just being put together. The estimates are we could be down to 17%. Next slide, please. For this particular slide, and I'm happy to share the slides for participants who want to read them in more detail, but I want us to zero in to the left column, the one that says HCI indicators, left completely at the bottom, which says fraction of children under 5 not stunted. And that's basically showing we are at 26%. That's the yellow dot is Kenya, and the other smaller dots in different colors are other countries. That kind of shows where we rank in others. Our HCI score does really well because of schooling. So if you scroll up on the same column and see expected school years, our children are expected to almost all have 12 years of schooling. So we do well on schooling, but we don't do really well on stunting. Next slide, please. This is a conceptual framework to understand stunting, and I don't think I'll go through it because I believe most of the participants here understand, but they're basically nutrition-specific interventions and nutrition-sensitive interventions, and all these kind of just contribute into who you are as an adult, your school performance, your cognitive and social skills, your chances for morbidity, mortality, and eventually your work productivity. Next slide, please. So stunting is one of those cyclical processes which has intergenerational effects. And science has shown us that women who were themselves stunted as children have a tendency to have low birth weight children and children who therefore may suffer stunting. Next slide. And this cycle becomes really difficult to break, knowing that stunting can reduce, can increase GDP by up to 11%. And can raise adult wages by 5 to 50% and can increase school completion. So I'm just trying to depict for you here that today a child who is under 2 and is stunted, it's not just a problem that will end in his or her generation, well, her especially, her generation. It's to affect their full adult potential and unfortunately even into the next generation. Next slide, please. Next. So this just kind of dives into what our statistics look like specific to Kenya. And I want to draw to your attention the national average there will be the extreme right red bar. That's 26%. But look at West Pokot, almost 50%, and closely following Kitui and Kilifi. And then peculiarly, for some of you, you'll see Nairobi looks quite low, and you might say, it's because it's in an urban area. It's actually less than 12.5%. Next slide, please. However, if you look at the absolute numbers of children who are stunted, Nairobi actually has the highest. Of course, because Nairobi has a much higher population than West Pokot. And you see West Pokot somewhere like 7th from the right. So the two slides are quite reflective for us when we start zeroing in onto the why children are stunted, not what necessarily causes stunting. I think we know that, but why are they stunted? And it's fine. Go to the next slide. You can see how the ASAL the ASAL counties look like. I don't think this is much of a surprise. Next. And so for this particular slide, I tried to summarize the highest absolute number of stunted versus the incidence. And you see the summation on the right, and the right textbook, the 15 counties have both the highest stunting rates and the absolute number of stunted children. Look for your county and ask yourself what you're doing about it. Next slide, please. This slide in particular shows the disproportionate effect of poverty on stunting. You can see in the lowest wealth quintile, which is the extreme right, you've got stunting rates as high as 35.9. However, I want to draw the attention to the richest. 13.8 is still not good. Even amongst the richest quintiles, it's not entirely a wealth issue, even if it's, almost 3 times the prevalence. Next slide. This particular slide just shows you what the relationship between gross national income and stunting would be. And in general, the wealthier a country gets, the less the stunting should be. And you can see where Kenya kind of sits in that graph. Next slide. So this would be the second to last slide. I just want to draw your attention to some work that the Presidential Policy and Strategy Unit is starting to think about in relation to stunting and its effect on human capital. We looked at all the areas that are, are composite of the human capital index and asked ourselves, where would be the sharpest entry point, what would be the best entry point towards alleviating the effects of a lower human capital index, harnessing the demographic dividend, as it were. And really the focus is now to start looking at the qualitative as opposed to the quantitative. I've just gone through a bunch of slides telling you who is stunted and where they are. What you'll be surprised by, and I'm almost sure I will have challenge to my position, is that we actually do not know necessarily why. So we've got many theories, and I think that's on my last slide. Next slide, which is the last one. Yeah, so we've got many theories as to why children are stunted. So, they either do not absolutely have food, or is there a trade-off of what we consider healthier foods or more nutritious foods, or what are considered urban foods? So are people going to the shop and choosing to buy bread instead of probably buying the arrowroot or the sweet potatoes? Is it a cultural issue? In our community, we don't eat this particular food or this other one, and the ones that we eat are not available. Is it an issue of a gender disparity? Is it that you can't make the decision as the woman in the house on what to feed the child, perhaps because you don't have access to money? Or is it a composite effect of perhaps one or more of all the ones that I have mentioned? And we want to hear from the households themselves. What are the things that influence your decision on what to feed the child? And how can we come in at an entry point that meets your need? So where is the highest contact you have with the society? Is it the church, for example? And I think I saw Canon Chris Kenyan Statistics on earlier during the opening ceremony. If he has contact with 80% of Christian women in this country, knowing that 80% are Christian on a regular basis, i.e. weekly, how could I use his platform to start influencing some of the decisions we make around childhood nutrition? I'm going to stop there, Heshimiwa, and allow questions at the end of the presentation. Thank you.
Thank you very much, Dr. I think you come out very well. That stunting is actually a big problem compared to morbidity. We seem to be doing worse. It is still a challenge, and it doesn't even fall within regions as we would expect. Again, we also compared the family incomes. It also seems that even with good income, there's a problem. And you raised the issues. You have raised many issues. What factors? What are the entry points? So I think as the participants will come, those are the things. Looks like you are in a place to get policies to first of all answer this question. But we will leave that to the participants. Please keep what you want to ask. You can even actually put them in the chat box when we come to raising issues so that we can share. With that, we'll just move. You are doing well in terms of time. Dr. You are bang on time. We'll move to the UNICEF presentation, Childhood Morbidity and Mortality, the experience of UNICEF in Kenya. I think that will give us a broader view of what is happening in the whole country. Thank you, Mr. Wallman. Please let's have your presentation.
Thank you, Dr. Nyakal, Chair, and thank you to the great presentations by Dr. Wangari and Dr. Kituku. I must admit that I received the request to present only last night, so I put together quickly a few slides. But I will be also speaking on issues which are beyond the slides. And also, I took note of the excellent presentation by Dr. Kituku and by Dr. Wangari, so I will try to avoid duplications. My name is Dr. Yaron Wallman. I work for Unicef Kenya. I'm the team lead for health and working in multiple countries around the world before arriving to Kenya approximately 3 years ago. And just to mention that UNICEF, as part of the UN system here in Kenya, is working very closely to support the government. So it's not that UNICEF has its own programs. UNICEF is really focusing on supporting the government. And given the fact that Dr. Kituku has provided an excellent presentation regarding the evidence and the statistics, I will try to go a little bit beyond that, beyond the narrow lens of health, to look at some determinants. But let's go through, and I'm very happy afterwards to look at different aspects and to respond to questions, trying to be brief so we can have sufficient time for the panel discussion and to answer questions. A few numbers and figures. I think Dr. Kituku has shared with us very clearly the trends for under 5 mortality, but we can see that while under 5 mortality has been reduced significantly in the country, the reduction in neonatal mortality and in infant mortality is a little bit more slow, and we will be discussing that, and there's still a long way to go in terms of achieving the SDGs. Next. Thank you. That is a slide which is very similar as well to one of the slides of Dr. Kituku, showing very clearly the main reasons or the main causes of under 5 deaths here in country. As Dr. Kituku has indicated, 41% here in Kenya are related to neonatal situations. But just to mention here very clearly as well that all of these causes have very clear interventions which are high impact, which are usually low cost, and which are easily available. So nothing here requires tertiary care, and most of the causes of under 5 deaths, including neonatal care, are actually preventable with high impact interventions which are available here in Kenya. We will be discussing in a moment why is it that actually we still have high rates of morbidity and mortality. But we can see, even for the neonatal mortality causes, there are easily available interventions. I think that also Dr. Kituku was very clear about that in his presentation. As you will see here, nutrition issues are missing here, and they mainly come under the other in terms of severe acute malnutrition, which is contributing to mortality, and then issues which are linked to stunting, which is more contributing to the longer term morbidity, and as my colleague Dr. Wangari has mentioned, also issues regarding suboptimal development of children, and then suboptimal reaching to fulfill the full potential. So all of that is under others, which are very important causes. Next slide, please. This is where, at least for me, the presentation is starting to get quite interesting. We saw from Dr. Kituku's presentation as well that we can see that there's impressive improvement in Kenya in terms of the indicators. And we can see here all of the different indicators in terms of, the average coverage, and many of them have quite good coverage. We will see that at least some of them still are relatively low coverage in terms of antenatal care, in terms of intermittent prevention treatment for malaria, for pregnant women, neonatal tetanus protection, again for women, skilled attendant at birth, early initiation of breastfeeding and exclusive breastfeeding. Unfortunately, still quite low coverage. But you can see, colleagues, that even for the interventions that have quite high coverage, there's a huge disparity between the different counties. These are the different dots here. And I think that we have seen it also in the slides from Dr. Wangari regarding the stunting. You can see that, some counties are doing very well, but other counties are doing very, very poorly. Even for high impact interventions like immunization, for example, where the average is not too bad. Also, of course, there's always space for improvement, but there are still so many counties which are still doing quite poorly, unfortunately. And even within the counties which are doing relatively well, there are pockets in which there are still vulnerable communities and vulnerable parts of the population which are doing quite poorly, in which really the government with development partners need to focus more in order to be able to reach those. Next slide, please. Here is a slide which actually shows, and I think Dr. Wangari was also making reference to that in a presentation, but here we have a little bit more evidence in terms of the impact of poverty or wealth or lack of wealth on the coverage of interventions. And we can see very clearly that the 20% poorest, the bottom quintile, they have a significantly lower coverage of all of the interventions, all of the higher impact interventions. The lowest quintile is in red here. I really would like to shorten my presentation so we can pick up and have the more meaningful discussion. I'm sure that the presentations will be shared by the Secretariat with all participants, and the numbers and figures here speak for themselves. Poverty is such a huge contributor to the inequities and the morbidity and mortality here in Kenya. And that is also linked to the last slides, in which I will be speaking a little bit about the support that Unicef is providing to the government of Kenya, focusing also on poverty reduction. Next slide, please. This is a slide which is related to bottlenecks and barriers, and like all of the slides that I have, these are not Unicef slides, they're taken from government presentations and government workshops and government working groups because we work with government data. So just to summarize a little bit, what are the bottlenecks and the barriers in accessing and utilizing, sorry for the acronyms, HII is High Impact Interventions for Newborn, Child and Adolescent Health Interventions here in Kenya. So the first one, which sometimes we have a tendency to forget, is really everything to do with socioeconomical determinants. I already mentioned the geographical areas and the fact that some counties are doing quite well and some counties are doing much less well, and even within the counties that are doing well, there are pockets that are not being reached adequately, and we really need to, in each county, to do a mapping to make sure that all the most vulnerable are reached. And there's a lot of work which is being done on that with geospatial mapping, which is very interesting, and a lot of evidence which is coming up regarding that. The specific population groups, I already mentioned the wealth quintile, the most poor, but we all know the importance of maternal education. When women are more educated, the children are highly likely to be better nourished and receiving better medical care. So maternal education is highly important. Gender disparities are so important. When women position in society and in the community is high, when they have the decision-making power, the health situation and of their children and all other issues which are related to the children, and especially their daughters, like Dr. Wangari has said, improves as well. And then we have the urban-rural disparity, and again within the urban areas, and we've seen, for example, for stunting that in Nairobi, the stunting on average is lower, although the numbers are still very high. But we also know that in Kenya, like in many other countries in the region, urbanization is huge. And we know that there are rapidly increasing numbers of urban poor who live in informal settlements, and over there they have no community support, no community networks, and their indicators, their status in terms of child morbidity and mortality is even much worse from recent evidence and in the Asal counties, for example. So even within Nairobi we have huge disparities, as we all know. That is linked to the vulnerability which I'm mentioning here. We have nomads, mainly in the Asal. We have the informal settlements, and we have others who are just significantly more vulnerable and need a lot more attention and support. And I mentioned already the poverty and financial access. We know that there are a lot of efforts by the government to address that through universal health coverage, but there's still a lot of ground to cover there. And I will mention that a little bit when we speak about UNICEF support to the government. We have what we call supply side barriers in terms of the provision of services. We already mentioned the coverage of high impact interventions. We have supply chain issues in terms of the availability of commodities. We have long distance to health facilities. And in Kenya, like in many countries in the region, the coverage of many of the services is quite satisfactory on average, although we said that the average hides huge disparities. But more and more the issue is on quality of care, and especially for newborn and maternal health, the quality of care is so important, because as long as the quality is not addressed, even if the coverage is addressed, but the quality of the care is poor, we have a major issue in terms of the morbidity and the mortality. Then, of course, we have issues which are linked to demand side. We need to remember those. All of us as public health professionals, it's not only about the supply side, it's not only about the provision of services, but as the communities, as the parents, as the children, really wanting, understanding the importance of receiving the services. Everything to do with care-seeking behaviors, everything to do with, different cultural beliefs and practices. Again, I mentioned the status of women in terms of literacy, decision-making power, poverty. And then a lot is about also health providers' attitude and behaviors. I think all of us know that that creates a huge challenge sometimes in terms of women and children seeking care. And lastly, on these slides, these issues which are linked to the enabling environment barriers, the fact that the workforce distribution is not equal, there's low productivity, there's low absenteeism, industrial strikes, and issues I think that all of us know very well. There's the issue of data availability, which is quite good here in Kenya. There's an excellent health information system, but is the data really routinely utilized in order to make decisions, in order to address bottlenecks, in order to access the most vulnerable, including very, innovative approaches in terms of geospatial information systems? Is that evidence which is really at the fingertips of decision makers? Is that being utilized routinely by health administrators at county and at national level in order to take the right decisions in terms of prioritizing the interventions and the resources? Then we have the policies and the guidelines. We have so many of them here in Kenya. They are excellent, and I think that my colleague Laura will be speaking about that a bit. But are they really implemented adequately at county level? We know that the system here in Kenya is devolved. The 47 counties are the ones accountable. And do they have really the resources and the policies in order to implement? And lastly, also linked to the devolved health system here in Kenya, as we know, is the devolved system really well coordinated between the national level and the county level? What can we do to better coordinate and to ensure that the counties that really have the mandate to deliver health services are empowered to do so? Next slide, please.
Sir, you have just 2 minutes, please.
Thank you, Chair.
It's very interesting, but we have a time constraint.
That is understandable, Chair. I think it is the last slide or maybe one before. I will accelerate. So a few of the areas of work that UNICEF is supporting the government, I will not go too much into detail because I actually would like to speak a little bit also about what is not in the slide. UNICEF is providing a lot of support to the government for maternal and newborn health in terms of strengthening and improving quality of care, supporting the implementation of different high-impact interventions, and really supporting UHC rollout. UNICEF is providing a lot of support for immunization and child health, increasing the equitable access and quality access for key vaccines, which are part of the National Immunization Program, supporting the rollout also of COVID-19 vaccines over the past few months, strengthening the supply chain for immunization, especially cold chain equipment, and supporting policy planning and budgeting for community health and primary health care, again, providing a lot of technical support at national level and at counties, working on supporting the government to develop different policies, including for early childhood development and nurturing care framework. And an area which is extremely important because Kenya is moving into a status of low middle income country and hopefully soon a middle income country. So actually the resources of the government by far they pass the resources that development partners have available. But supporting the government at national and county level really to prioritize the allocation of resources to make sure that the resources which are being allocated are utilized effectively on the high impact interventions and really focusing on the most vulnerable. And finally, also working on emergency preparedness and response, including for COVID, including for drafts, including for floods, including for impact of climate change. I think there's a specific thematic group regarding climate change, but it cannot be mentioned also here. Climate change and its impact on children, morbidity and mortality is extremely important. And lastly, working on different issues which are linked to public financing for high impact interventions for children, and working on demand generation, community engagement and behavioral change in support to the government. Apart from that, the areas that are not mentioned here but are extremely important are nutrition interventions, nutrition specific and nutrition sensitive areas of work, preventing malnutrition and preventing stunting as well. And then support also for water, hygiene and sanitation, because we know that water, hygiene and sanitation are very important causes of diarrheal illnesses. And that is an area that Unicef is supporting the government significantly as well, both at national and at county level. Next slide, please, which is the last one, I believe. That is a bit a complex scheme of the support which is being provided. I will skip that because of interest of time, but I hope that the presentation will be available. I just wanted to thank you, Chair, and fellow panel members and all participants for your attention, and very much looking forward to our plenary discussion after the presentation of my colleague, Dr. Laura. Thank you very much.
Thank you, Dr. Wallman. Very extremely interesting, although you went a little bit beyond time, but very important. You actually showed, your data showed that the areas of high impact coverage was actually lower in the neonatal, in the antenatal and neonatal period. Then that explains why neonatal death is still our biggest problem. You showed the bottlenecks, what's happening, and then you said something that I think our colleagues, particularly from the PASU and the Ministry of Health, Council of Governors, the policies, guideline as works in a devolved system, and also coordination. And then the support you have. Well, we are really enjoying this. I hope everybody is, because it is flowing very well. With that, we'll go to our last presentation. Then we can have what I believe will be a very interesting plenary. Dr. Laura Oyengo, Division of Child Health. Yes, Dr. Welcome.
Thank you, Chair. Thank you, Honorable Nikal. My pleasure to be here. As I do my presentation, I do have data, but I'll rush through the data that has already been presented just to build up on the policies and the strategies we have at the Ministry of Health to mitigate against child deaths. My name is Dr. Laura Bonareri. I head Neonatal and Child Health Division at the Ministry of Health, Kenya. This was the outline of my presentation. I was going to show the global cause of under-5 mortality, which has been shared. I was also going to show a few indicators on neonatal and child health that were done in the Kenya Demographic Health Survey 2014. We do have program-specific child morbidity data, and then the strategies to address neonatal and child morbidity and mortality. So this has been shown, and it's very clear to us that among the under 5, the newborns, that is the age of 0 to 28 days, is most affected, and they contribute to almost half of all deaths in the under 5 age group. When you look at our Kenyan statistics, from the data that has been presented by Dr. Yarun and also by Dr. Kituku, one thing we need to take note of is that every day in Kenya, around 280 children die from issues that are largely preventable. And as Dr. Yarun has said, these are high impact interventions that don't require a lot of investments in terms of resources to mitigate them. When you look at the cumulative numbers in Kenya, 108,000 children die before their 5th birthday. This is a very large number indeed. And out of this, we have 40,000 dying within the 1st month of their birth. And I want us to take note of these statistics as we now go into the indicators. This has been shared. Dr. Kituku shared a very nice graph of under 5 infant and neonatal mortality. But we do have health prevention and health promotion programs that are available at no cost to that child. And yet we find that when you look at the coverage, for example, vaccination coverage in the country by county, we have counties where only 1/3 of the children are fully immunized. And it's not surprising to note that these are the counties that also have very high percentage of children who are malnourished, very high proportions of populations who are not fully literate. So as we try to develop our policies, we need to address the vulnerable populations in the country as witnessed from the data that is shown in the county to county variations. Nutrition status has been shared, and it is worth to note that over the years, as per the Kenya Demographic Health Survey, there's been a reduction in the number of children who are stunted, wasted, and underweight. But we are still not according to track to achieving the goals set that we need to achieve by 2030, which is only 9 years away. One low-cost intervention is breastfeeding our children. In a country which has very high literacy levels, you find that only 61% of children are exclusively breastfed between the age of 0 to 6 months. And we want to understand why is it that one caregiver will opt to breastfeed their child and another one will opt to add complementary foods or water or milk to that child? How do we create policies that support parents and caregivers so as to breastfeed their child exclusively the first 6 months of life? And we do understand the benefits of this exclusive breastfeeding. We are a country where we distribute long-lasting insecticide-treated nets to antenatal mothers and also at the well baby clinics for anyone who's under 5 years of age. And yet when you look at the survey, you find that the percent who sleep under an ITN, that insecticide-treated net, the night before surveys, only 54% of the children sleep under this net. This is a no-cost intervention that has been availed to our population. And yet you'd find the net is available in the house, but the children are not being given to sleep in it. What is even more alarming is that in households where there is a net available, only 77% of children under 5 sleep inside that net. And we need to address the information that is availed to the community levels. How do we educate our communities so that they know the importance of why we are distributing these nets as a country and to this particular population? I stated that we lose around 280 children per day. And as a division, we are interested. Which are these parents who bring their children to the facilities? And when we look at the statistics from the Kenya Demographic Health Survey, you find that only 66% of caregivers bring their children when their child has an acute respiratory infection. Only 63% of them bring their children to a facility when their child has a fever, and only 58% of them bring their child when the child has diarrhea. And the question arises, where do they go to seek health services? Do they go to the pharmacist? Do they go to another parent who is in the community? And it really brings out the importance for us as a division to work together, closely together with the Community Health Division, where we educate our community health volunteers to reach these other parents who do not bring their children and see what interventions can we provide at the household level, and also how do we link up the household to the nearest health facility where these parents can, where the children can receive the health care. Having said that, we have very many programs in the Ministry of Health who have specific interventions for children. And I want to share morbidity and mortality data that is program specific, just to see what the landscape looks like. We've talked a lot about neonatal mortality, but that's just the tip of the iceberg. We lose very many children when the mother is still pregnant, right at the time of delivery, and in the first 7 days of life. I've here presented data on the numbers of fresh stillbirth, macerated stillbirth, neonatal deaths 0 to 28 days. And as a country, we began last year collecting data of how many children we lose between the ages of 0 to 7 days. When we looked at this data and when we compared it, I haven't presented it here, when we compared it to data from previous years, we expected that the data for 2020, being an year where we were faced with a pandemic, would be very bad as compared to the previous years. But what surprised us is that these figures are largely constant. When you look at data for 2018, 2019, which I haven't presented here, excuse me for that, and 2020. So when we look at that neonatal death, the perinatal death, we need to look at that pregnant woman. How do we support this pregnant woman to stay healthy, to be able to deliver in a facility where there's skilled birth attendants, and also to provide supporting staff who will take care of that neonate in the first 28 days of life. That and only then will we be able to reduce this. And this can only be done if we provide quality healthcare. We also look at the number of children attending the outpatient department. And this is very important, especially to counties, so that they can be able to see the burden or the volume of patients who access their health facilities, and they can be able to provide the staff, the commodities, and the equipment required for this population. In 2018, we had 18 million children attending outpatient department, and this rose to 19 million in 2019. Last year, we do say we had a pandemic, but on top of that, we had a health workers industrial action, and this significantly brought down the numbers to 15 million children. So where were these 3 to 4 million children who did not attend the health facilities? What happened? Where did they go to seek health care? When there was a health worker strike in the public health facilities, what did counties do to ensure that the other facilities that were providing health care were able to absorb this burden? I'll go to our performance as a country when it comes to immunization. And here we are seeing the DPT3 coverage. This is all 2020 data for select antigens. And you can see our coverage, though it's high at between 80 to 85%, in December, there was a drop. And this is true for most of the antigens across the board. So for the immunization program, they are currently having a supplemental National Immunization Day for polio vaccine. And this is mainly to reach these children who are not reached with specific antigens, and also to educate the community the importance of bringing their children for vaccination. So this informs decisions on the coverage and also the fully immunized child coverage, and helps the immunization program put in place interventions that address these shortfalls. HIV, we know the vulnerabilities of children living with HIV. There are children who need to be identified early and initiated on treatment early. As at last year, there was an estimated 106,000 children living with HIV, out of which 68,000 had been identified and initiated on antiretroviral therapy. For children, it's almost an emergency to start them on antiretroviral therapy because if you do not initiate it within the first 2 years of life, you lose 50% of them. And if you delay much further, the ones who survive, they develop complications, and rehabilitating the immune status becomes an uphill task. So from the HIV program, they also need to look at the children who've been missed out from identification and treatment initiation and put in place interventions that are able to reach this population. The next major condition that we have is TB. In Kenya, we have around 5,000 children who are identified as TB positive. This represented a 32% drop when you compare it to 2019 and presenting 2020 figures. And it shows the top 5 counties who contributed to the 5,000 children identified as TB positive. Tana River, Turkana, Laikipia, Mandera, West Pokot. These counties keep coming up. If we looked at Dr. Yarun's slide on counties which have very poor immunization coverage and also Dr. Wangai's slide of counties which have malnutrition, you will see these counties featuring. And now they come up again when it comes to TB. When it comes to TB, treatment success is measured by when the patient completes their treatment and they turn out TB negative. But when you look at children, we do have 89% treatment success rate, 93% cure rate, but we have a 4.8 death rate. And all the children who are identified, 3.9% are lost to follow-up. And the TB program, one major question they ask is, lost to follow-up where? Where do children go? Children do not wake up and leave the country and relocate to another country. So they are somewhere in the community, but somebody is not bringing them to the facility to get their treatment. So an area that the TB program is looking to strengthen and address, the lost to follow-up and the children who do not, who are not completely cured from TB. Violence in children, another major cause of death in children, and from the global burden of disease, injuries result to 5% of all deaths in the country for those aged less than 20 years. When we look at data from the National Transport and Safety Authority, a total of 837 children died in road accidents, and I have given a breakdown of the age groups, around 200 in each age group. Easily preventable deaths. We know children should not be left wandering in the streets by themselves. They don't have the cognitive abilities to keep themselves safe in the streets. But moving on, in the theme of violence in children, we did have a VAC report, Violence Against Children report in 2019, where we found that nearly half of females and more than half of males had ever experienced childhood violence. And among those, the females who'd experienced childhood sexual violence, nearly 2/3 of them experienced it multiple times before the age of 18 years. When it comes to physical violence, the male child is worstly affected, where we find around 52% of male children ever experienced childhood physical violence. And it speaks now to the mental health department. Have we trained our parents and caregivers to care for their child, responsive caregiving? And when these children are affected by physical violence or sexual violence, what mental health facilities are there for them to access so that they are able to unpack whatever it is that they are going through?
Okay, Dr. the 2 minutes, the summarize.
Okay. So we do have a lot of policies and guidelines that support interventions from all these programmatic area. As a ministry, we have a declaration to end pneumonia deaths in children under 5. We work with multiple stakeholders. We've heard of the school transport regulations where all buses were painted yellow and seat belts introduced in the school buses. We do have the Sexual Offences Act that specifically has content for when an underage child is violated or defiled. We prioritize vulnerable populations. We have the Beyond Zero that tries to reach every child in Kenya and every mother in Kenya. We have Malezi Bora, where we conduct vitamin A supplementation, we give dewormers, and we have a health package for children across the country. Our national immunization campaigns, we have prohibition of female genital mutilations, all meant to address vulnerable populations. We work together with donors, Global Fund, PEPFAR, among other donors, so that we get funding to support our activities. We do try to work with research institutions and academic institutions to accelerate uptake of breakthrough innovations, for example, NEST, Newborn Essential Solutions and Technologies, establishment of gender recovery specialized clinics across the country. We track our progress with transparency, accountability, and inclusivity. We have performance contract at the Ministry of Health, signed from the CS level right up to the heads of department level, that we are all accountable to achieve every year. In our division, we work in technical working groups, committee of experts, which provide guidance. And we also work together with the counties to ensure that what we are speaking at the national level as policymakers is implemented in the county level. And we do this through the 6 pillars of health systems, strengthening in policy, that is governance and leadership, health financing, universal health coverage of high impact intervention, addressing infrastructure, equipment, and commodities that are specific for neonatal and pediatric patients. We use health information for decision-making, the Kenya Health Information System, program-level data, and also global modeling of data. And also we address human resource for health. We understand that children need staff trained in nuances that are specific to the neonatal and the pediatric patients, and we advocate for that. Thank you very much. I've come to the end of my presentation. Thank you, Chair.
Okay, thank you, Daktari. I think that has been good, and you really actually concentrated on utilization of services, and you've shown with your data that we have many areas, you've listed them, starting with the outpatient attendance, use of nets, HIV treatment, TB follow-up, road traffic accident, violence and child abuse, and mental health. The deficit in utilization of services and availability. I think you've gone on to say what you are doing, working with partners, research organizations, the tracking process that you have, and the partnerships. So all partners, I think this has been a tremendous session, particularly for me. And what I can say is basically it's been shown that we are doing well in child mortality, but we are not doing well in the area of neonatal and perinatal care. And we've also shown that although we are doing well in child mortality, under 5 mortality, we have a problem of stunting in particular. And Unicef has actually shown data and what areas that we need to act on and what we need to do. And Laura has actually eventually looked at the deficit we have in uptake of services. So really, I think we have really all the information we need here, and I would say at the onset that if you have Dr. Kituku, Dr. Nganga from the PASU or the strategic unit, and Laura, and with the information from UNICEF, we have answers. We just have to put it together. With that, I'll open it up for other participants. You can raise questions, write them up, and maybe we'll take them in sessions. First round, you can take about 5, and you have to say specifically who you are addressing. If it's a comment, fine. If it's a question, address it specifically to the panelists. Then we will have a summary at the end of it. So here we go. Where are the participants? Are the participants with us?
Yes, Chair, we are around.
Yeah, I can see the panelists are there, but now I'm looking for the participants who want to make comments, ask questions. Or were we talking to ourselves?
Dr. Nyakal, I'd like to ask a question. This is Dr. Sheila Macharia. Good afternoon.
Doctor, how are you?
I'm
Fine,
really
for a
well.
long time. Go ahead, go ahead.
Yes, I'd like to address this perhaps to Dr. Laura. I would have wanted to hear how she thinks the primary healthcare approach that was mooted by the Ministry of Health, I think a year or so ago or two, how that could possibly make a difference in the counties where she mentioned particular concerns, whether it was malnutrition or high TB, but given the bottlenecks that were alluded to earlier by Unicef, how does she see the primary healthcare approach helping or not for those areas of concern? Thank you.
Okay, thank you, Sheila. Next question, we will take 4. We'll have answers to them. Then we can take another set. Who has a question, a comment? While we are waiting. Yes.
This is Patrick Adera.
Yes, Patrick. Welcome. Let's have your question directed to.
My question is directed to, it's just a concern on top of what UNICEF has raised, because I also support an organization that supports community health strategy. So my question is that we realize that most of the neonatal deaths and infant deaths would be prevented if interventions are given at the right time. Unfortunately, looking at most of our counties, the access to health services facilities is a bit complicated because of various challenges. So my question is, what is it that we can do to the community health strategy to make sure that the CHVs and the community health structures are effective enough to make sure that some of these cases are managed at the community level, and those that get to the facility after some management have been initiated at the community. Thank you.
Yes, thank you. I think that question go to UNICEF and also to Dr. Laura from the ministry, and even to Wangari if they have. Okay, next question. Who else was listening to us? We could have possibly had only 2 participants, because I can see the screen is relatively full. Okay, while we are waiting, can we have answers to these questions? Sheila Macharia addressed the question to Laura. How can primary health care make a difference? And I think it also relates to the next question, but Dr. Laura, can we start off?
Okay. Thank you.
Okay.
Primary health
Stephen,
care,
we have seen you. We'll come to you, Stephen.
primary health care
Laura,
is
go on.
important to child health. So primary health care is very important to us working for children. And the reason being is that multiple studies have shown that parents and caregivers prefer taking their children to the facility that's nearest to them, and in a facility where they are more or less conversant with the services available there. So for us, we look at primary health care as being one of the backbones if we want really to achieve and reduce the morbidity and mortality caused by the number of conditions that I presented. However, when you look in our country, you find that the staffing and the equipping of primary healthcare facilities is not adequate. And as a division, we've come up with a few guidelines to address neonatal health and child health in terms of service delivery at primary healthcare facilities. But this can only be possible if we work together with the counties and they address the issues of staffing, equipping, and availing commodities at the primary healthcare facilities. So my position is that primary healthcare is very important. In fact, when we look at UHC, we believe is the bulk of UHC support goes to the primary healthcare facilities. We'll be able to make a positive impact. However, counties need to come on board and ensure that the level 2, level 3 facilities are able to provide the services that pertain to neonates and children. So we do support primary healthcare and we do believe it's important. Thank you. Thank you, Chair.
Yes, we look at primary health care, but we also need to support it with level 2 and level 3, and also enable the community health workers to actually do their work. I remember that program when we started, it was supposed that they'll even be able to get some supplies that will help them. But I think Laura is from the ministry, so that's a good thing. Okay, thank you, Laura. Sheila, you got your answers. Are you satisfied?
Yes, thank you. That was very good. Thank you, Dr. Laura.
Okay. Then the next question, Patrick Adera, he asked and directed it to UNICEF, but I think even here, Laura's comment will still be satisfactory, but I would like Dr. Wallman to say something because he showed lack of access. And Laura again showed that even when the services are there, sometimes they're not used. So I think both may actually address this issue. So Dr. Wallman, please. We can't hear you. Can we hear? Who was managing this? We seem to have lost the sound. Dr. Wallman, can you hear me? Can we hear each other?
Yeah.
Okay, that's better. Go on, try. Well, we've lost the sound. Who will help us here? Let me see if I can get some. Yes?
Ben Aqua and Erastus Kivia are co-hosts. They should check because they're the ones who are hosting this. Ben and or Erastus or Samuel Obanga.
Ben, do you hear us? Ben? Ben Aqua?
Hello, this is Samuel. Hello, everyone.
Samuel Lubanga?
Yes.
We have lost sound. Can we get the sound back?
This is Samuel Lubanga, one of the co-hosts, just to communicate to you that we are waiting for the rest to convene back. But if you are done with the session, I think it should be okay. For us was just to allow you to close on what you are concluding. If you are done with your QA, it's all right. But as here at the control center, we shall have this team remaining as it is because this is the main plenary. The rest are going to join this session. Thank you.
Are you saying we are done now? We can't proceed?
No, what I'm stating is if you are done with your thematic session, it was a discussion, it was engagement with the members within this thematic sub-theme. Ours was to reconvene everyone back. So the communication was that we have people summarizing in whatever they are doing, so that eventually we can all settle at it.
Okay, can you give us the sound to summarize? Can you give us the sound so that we summarize?
They have it.
One of the panelists cannot be heard.
We can't hear.
Okay, it's all right. It's all right. Who is that? Okay, a moment.
Dr. Wallman from Unicef.
But perhaps I need to inquire. Because we have several of us joining using the same link. Could they please check if they are muted? Perhaps to unmute. Check your system, please. Just check your mic. It could be on mute.
Dr. Wallman, unmute. Actually, you are muted. Okay. Are you okay now? Dr. Wallman? No, he's not muted. And no sound.
Yeah, because we can hear you very well. We can follow. We've been following through very well. And also the other participants who are speaking into the meeting, we will hear them. Over to you.
Okay, unfortunately, we can't get Dr. Wallman, so we'll proceed. Can Laura, can you be heard? So that you can take on the issue of community strategy.
Can you hear me, Dr.?
Yes, we can hear you, although we can't see you, but we can hear you. Go ahead.
Okay, community strategy. One thing about the community strategy is that the Community Health Division has been tasked with setting up community units across the country, 100% coverage of community units. This they've been doing, and I think from their last data, they are at, if I'm not wrong, 70 to 75% coverage as we speak. This is because of the importance the community health volunteer has shown in being part of the health systems, in delivering health packages and health education to the communities, to the households, and generally improving the health indicators across the board and not just neonatal or child health. They ensure that the pregnant women access antenatal services. They educate the pregnant women on delivery in facilities, and they also educate them on the importance of bringing their children for immunization. We do train our community health workers, the different divisions. I know the malaria program trains, the TB program, and other divisions. And at Child Health, we have what we call an integrated community case management of illnesses in children. So we do have interventions that are delivered through the community strategy, but we all work under the umbrella of the community health division. So that one is being done, Dr. Nikal, and it's quite robust in this country. Thank you.
Thank you. Maybe you can have one final question. Who wants to raise a question, then we'll actually summarize as we've been asked to.
Dr. Nikal, if you allow me, I can also comment a bit on the community strategy from the counties. Yes, thank you. Yeah, thank you, Chair. I just wanted to alert participants that under universal health coverage, which now is being rolled out across the 47 counties, actually the community strategy is a key pillar. And as we all appreciate, universal health coverage basically is aimed at achieving 4 main objectives. One, ensuring that every Kenyan can access healthcare wherever they are. Number two, ensuring that there is equity in the access of healthcare services. Because we all appreciate that since independence, there's been a skewed allocation, if I can call it that. And you find that the best healthcare facilities are being in the big cities. And even in the counties, you find the best are in the biggest town within that county. But now with the universal health coverage, we want to ensure that every person, whatever corner of the country they are in, they should be able to be, basically there should be equity to have a good health facilities. Third objective, of course, to ensure that every Kenyan can access quality healthcare. And the fourth objective, to ensure that healthcare is affordable to all. And affordability does not necessarily mean free. But of course, we must appreciate that because of the poverty levels in the country, there is a big percentage of Kenyans who cannot afford to access healthcare. And therefore, that's why now across all the counties, there's an ongoing exercise, which is basically registration of indigents, basically the poor of the poor households, whereby now then the government, both national and county, can be able to pay for these indigents to get NHIF cover, so that when they get sick, then they don't get, they don't fail to access healthcare because of their poverty. And even those who have a small income, then they don't become poorer because of seeking healthcare. If I give an example as I close, you can imagine a grandmother somewhere who is taking care of a grandchild, and that grandmother has one cow. And this grandchild, they get sick and they take them to hospital where they have to pay. And she doesn't have any other source of income. We've seen some of these good Kenyans, now this grandmother having to sell the cow, where this child was getting milk and other benefits. And then now she sells the cow, luckily the grandchild gets well. But when they go home, they are poorer, they can't have good nutrition because there's no milk. The milk she was selling to get, to maybe to pay fees and buy other things, they can't access. And therefore, universal health coverage is really going to help this country to ensure we get all this. Of course, most of the counties now are functional community health units with the healthcare community health volunteers who are getting stipends. And probably as I switch off, Chair, we might need at the national level to find out how we can get something more for these community volunteers, more than just a stipend. If there is a way we can convert them to become community health care workers. Of course, I know there's a monetary implication to that, but they are doing a very, very good work in the communities across the country. Thank you.
Okay, thank you. Maybe to just let you know, when we first wrote the policy document, it was actually community health workers. And I think it's because of fear of payment that we revised it and called it community health volunteers. But I can tell you, we are concerned. There's a bill in the assembly that is a community health workers bill that actually is coming. And somebody asks, why are community health volunteers not well trained? Maybe Dr. Kituku, you can make a comment on that. Then that was Valerie Akinyi to everyone, but we will ask Dr. Kituku.
Yes, thanks. Thank you, Chair. Probably we may need to give the person who has that question some background. One, these are volunteers. They are not on a salary. And therefore, of course, there's a criteria on how they are recruited. One, this must be people who are in the community, who live and stay in the community, meaning that it's not someone, most of them are not young, because we know there's a very high movement of young people from rural areas to towns looking for job opportunities and schooling and so on. But these are people who are in the community, who have interest in improving health and serving the community. And then number two, of course, we must appreciate part of the problem we've been having in the country regarding healthcare is when we approach it using a elite kind of approach. The people who are down there, those mothers, some of them, actually some of the community health volunteers are former traditional birth attendants. They may not have formal education, but they have some skills which now are being channeled the right way. And as Dr. Bonareri has indicated, there have been training modules which these community health volunteers are going through, and they are getting a good good basically education for that level, because the work we really need them to do at the community level is not to treat, is more of the preventive and health promotion. And then of course they're now giving basic things like deworming children, being able to encourage pregnant mothers to attend antenatal clinics, being able to motivate and encourage mothers and parents to ensure children get immunization and so on. And they are doing that work very well. We lose it when we try to imagine that these community health volunteers or community health care workers in the villages should be people who have gone to medical training colleges, because again, anyone who has gone to a medical training college, they are unlikely to stay in the village. They'll move elsewhere and they'll only be coming part-time. Thank you.
Okay, thank you. I think as we have been told, we've come to an end. I really must thank everybody. Yes.
I am imploring. This is Dr. Wangare, Elias Samuel Lubanga, to make a final comment, even as we are wrapping up, session chair.
Okay.
Will you indulge me? Thank you. Thank you very much. And I actually want to pick up on the comments, the very, very accurate comments made by Dr. Ansen Kituku. And I'll start by quoting the pediatrician who was my supervisor as an intern in Nyeri. And I will never forget one of the times we were very proud of ourselves as interns for following the pediatric guidelines book and ensuring that a specific child was born to a HIV mother, and we started all the correct treatment protocol. And I remember his words very clearly to date. More than 10 years ago, he said to me, Wangare, this book is a guideline. It is not an instruction. So for someone like you, I expect you to take this guideline, and then I expect you to apply the knowledge you have gained previously and make the correct decision. And this is actually the challenge that I want to give our participants today and to all of us. Let us remember, just as Dr. Kituku has said, when you're approaching actual implementation, what you have, either from the national level, from the global policy level, are guidelines. And we are lucky enough as a country to have health devolved. And so therefore, you in your specific county, in your specific jurisdiction, you take these guidelines and apply appropriately. Whether that is the primary healthcare approach, whether that is the community health strategy approach, that is actually the expectation. And Dr. Kituku and his colleagues, especially those who are participants of the pilot UHC program, have done exemplary well, especially with the community health strategy. Take it. Don't wait to be told further. You've been given the guideline, now apply. Even for those who are in the development partner space, the CSOs, I think I've seen some comments. Please remember that these are guidelines. It is now your responsibility to take the guideline and apply appropriately. Professor, Dr. James Dikal, my pediatrician was called Dr. James Kanyinge, who I'm sure you remember.
Yeah, I know that.
Thank you.
Okay, thank you very much. I must thank the panelists, Dr. Kituku, Dr. Wangari, Dr. Wallman, and Dr. Raura. What has come out of here, we have actually said where the problem is, where are the deficits, the policy issue that we need. And actually the four of you, particularly Dr. Wangari, working with Dr. Wallman, Laura, and involving the Council of Governors, we can put this together. Whoever is running this meeting, I think, should take this and actually develop a working document which we can. For there's no point having all these and talking and then nothing happens. All the participants that were with us, thank you very much. And I think with that, we'll call the meeting to an end. Thank you, everybody. I can see at the headquarters, they are waiting us to finish. Okay, thank you. We are done with this session.
Thank you.
Ken, are we okay? Ken Luaki?
Yeah, okay,
we are
okay,
done.
Dr. Thank you.
Okay.
Yes, thank you.
And the plenary, we hand over to everything to you. Okay, thank you. Meeting adjourned.
Thank you, Dr. Mikal. Thank you, Mheshimiwa.
Thank you.
Okay.
Thank you, our former Director of Medical Service.
Thank you very much. I lost direction.
So,
okay, thank you.
We'll still stay here. We'll still stay here. So don't lock out and don't leave the room. And the others will come and join us here. This is the main conference room. So the rest who have joined their respective sections will come back and join us here. The next 45 seconds.
Okay. Thank you. Me, I'll leave as I told you earlier. Thank you.
You're leaving, Doctor. You wanted just to say something before you leave.
Huh?
I wanted you to say at least something before you leave for the rest who are joining us again.
What I'll say is that, like here, the information we have got, I'll just tell you what they told us. We are doing well in child mortality. We have gone down to 43 per thousand, but we have found out that we still have a problem with the neonatal mortality, and that's where the problem is. We have also seen that apart from doing well in, although we are doing well in mortality, stunting is still a problem, and therefore our human index is actually low, 0.55. So that's not good enough. So we still have a lot to do. Unicef and has shown us that there are high impact interventions that are actually available and they are cost effective and they are not really expensive. And Claraura has indicated that even those high impact, low cost interventions are not being utilized, so that service utilization and even availability and quality are an issue. So in this area, we actually have everything we need, and the team that was here, they can put it together and actually make an improvement so that our children don't die, and when they don't die, then they have good development, including mental development. So look at the lower level, and devolution is an opportunity as much as it looks as a challenge, and the issue of community strategy and community health workers can help us solve this. So I think we have spent this time well, and you as organizers bring out documents, send it out to these people, and let's see how it will be utilized. Thank you very much.
That was the chair of the session on childhood morbidity and mortality. He had given his brief on the key critical issues that came out of their session. I think right now we are all of us we're all in the plenary. Whole team, I think we have all the other thematic areas are back. I want to again welcome you back to the main hall. This is where we're going to again ask the chairs of the sessions just to again in 1 minute or 2 minutes just give us key highlights of what was discussed in their respective thematic sessions. And then from there we're going to give direction on tomorrow, what we call tomorrow conference. So let me start with Dr. Ann Kasakala. Dr. Ann, she was the chair for the session of population size and growth. So Dr. Ann, just give us just 1 or 2 minutes. What were the key highlights from your panel discussion on your session on population size and growth? Dr. Ann.
Okay, thank you very much. This session focused mainly on the past population trends, looking at the size and growth. And then we also looked at the future of the population, as well as issues of how to manage the population. And some of the key issues that came up were, how do we manage the size and growth of the population? And what transpired is that at the national level, we seem to have very good strategies for managing, but we need now to focus more the lower levels because some of the lower levels still have quite high fertility, high mortality, And then we need to look also at issues of internal migration. And internal migration basically brings about urbanization. And urbanization, of course, has its own issues, especially in the informal settlements. And then there were issues of need for collaboration in terms of generating data for evidence of some of the, on population dynamics and use of these evidence, especially at the lower levels of CSOs and NGOs at the lower levels. How do they integrate population dynamics in their planning? And again, policies need to address the issues of population size and growth. I think basically those were some of the key areas that came out, but there's a lot more that was discussed, and maybe that will come out from the rapporteurs. Thank you.
All right, thank you, Dr. Ann. Thank you very much, Dr. Ann Kasakala. That was from the theme on population size and growth. We covered the issues of migration, urbanization, and the issues of pollution management of population size. Thank you very much. We'll now proceed to the next theme, which was on adolescent and fertility, which was chaired by Dr. Isaac Bashir. Just that they also give us the key highlights of what transpired in your group session. I was trying to move from, I was popping into the groups, and I think most of the groups, what I was, what I was impressed with the participation of the large number of participants. The other thing that I was impressed is the quality of the discussion. I was really impressed, very impressed. But Dr. Bashir, can you just also in a few minutes, just give us a highlight of what has transpired in your session? Thank you.
Thank you very much. Thank you very much, Dr. Mohammed Sheikh, the Director General for National Council for Population and Development. We've had a very interactive session. Actually, we thought the time was not enough. Not we thought, but we were cut short. And we had adolescents who were in the panel who could not do their presentations, but I would request if they are here just to introduce themselves before I give the highlights. Hope Nyokabi, just introduce yourself and what you're doing now, please, to have their voice.
Can you hear me?
Yes.
Go ahead.
Perfect. My name is Hope Nyokabi. I am a student at the University of Nairobi in my third year, currently pursuing a Bachelor of Laws. And also I currently host a show on a local television station that is aimed at just targeting the youth and talking about the lives of youth and their spirituality. But currently, I think the main reason as why I was invited today was just basically to listen into the discussion, and I really appreciate all the insights that I was able to gather from the discussion. But just to point out one thing that really I felt was not so much addressed as I would have wanted to be addressed in the presentation is the fact that, yes, in as much as we are talking about adolescent fertility in the country being sort of to what we could call a pandemic as of now, as a nation, we are shying away from the fact that we are shying away from and acknowledging that our young people are really sexually active, and we can only be able to curb teenage pregnancies and adolescent births by making sure that in as much as they're sexually active, let's put in place mechanisms of providing for them sexual education, which will prevent them from getting sexually active from a very young age. And even if they are, let's provide protection for them. Let them have contraception and family planning methods in place so that we can protect our nation and just ensure that we have sustainable growth and development for our children and our nation's future. Thank you very much.
Thank you, Hope, on that. We also have Mariano Anjiru Kariuki. She's 18-year-old, a Form 4 leaver with an A- from Modality. This is the lady who was trending in the social media, and we want to welcome her to listen to her voice. Mariano Anjiru.
Okay,
yes.
My name is Mariano Anjiru, and I'm really grateful for this opportunity. I had been welcomed to just come and be a participant, and I've really benefited from this conversation that we had in adolescent fertility. And one thing I can add is that I think that people need to reach more to the youth, because living in a ghetto, in a slum, there are various challenges, most of which are teenage pregnancies and drug and substance abuse by teenagers. And even this is a result of poverty and domestic violence. So I would urge people to step out and come and at least issue some guidance and counseling to these teenagers in the slum areas, because it's as if they feel left out, and they feel like there's no one who cares. So I think that someone should come and step out and at least help these girls. And I'm really grateful. Yeah, thank you.
Thank you, Dr. Sheikh, for that opportunity. I wish to be forgiven for that disruption of the main panel. In our presentations, we've had 5 different presentations from CSO, from our academia, from child health, and looking at statistics of adolescents, what their populations are, what their needs are, the lack of statistics on the 10 to 14, the balkanization of the different cohorts with different needs from 10 to 24 years of age, and the contribution of childhood from breastfeeding, conception, all the way to adolescent development is a whole trend of events that give us adolescents who can contribute to human capacity development. We have realized that 1 point increase in IQ contributes to 0.11% of our GDP, and therefore it is important to us to start the journey pre-conception. But malnutrition, as has been discussed in other channels, in other sessions also, is a strong contributor to our nation development. And therefore, from now onwards, we want to approach, we should approach this agenda as a multi-stakeholder agenda that is at the top priority of the country. And therefore, we will share the report on the summary. I do not expect to have this presented here, but it's important that we bring on board these youths and also look at the different cohorts within a heterogeneous population for development. Thank you very much. Thank you, Dr. Sheikh.
It looks like the internet is a bit getting fluctuating, but we got your message. Thank you for that feedback, Dr. Bashir. And then Yokabi and Mariano Anjiru, thank you very much. I think this conference, we look at the theme, is more focused on the youth, and I think what you have raised is a very relevant and important points. We will consider them in our population review. So thank you very much. We have tomorrow, and we're there for tomorrow. We have again areas I think where you can also do presentations and also you can contribute. So you're welcome, Miriam and Yokabi. Thank you very much, Dr. Bashir, on the theme. I think I joined that team. I saw it briefly, and I think the presentations were excellent, excellent. So I like it, and I just want to thank you, Dr. Boati and the team that were there, and Dr. Kiara and the last presenter. Now let's proceed to the next chair of the session on mobility and internal migration towards orderly mobility and productive economy. And also joined that one, and I saw when Engineer Francis Gita was presenting, and I think the vision he has for Nairobi and its metropolitan, I think amazing. So I want to invite the chair, Engineer Mairura Omwega, to again also give us a highlight of what transpired there. Welcome, Engineer. You're muted, Engineer.
Yeah, thank you very much. Thank you very much, Chair, for that. This was a very interesting session for sure. This is one of the sessions that really brings into light the issues of the devolution on counties and towns. And one of the key highlights from this session, from this particular session, yes, the devolution is now really pushing the issues of migration. Sorry, my thing is getting stuck there. So just a second, just a second, just a second. Okay, the evolution is driving migration in the counties, and hence the need to have planning within the counties. The need to strengthen counting in the planning in the counties becomes very important, looking at really what the provisions are now under the Constitution. Then also planning for mobility is an expensive exercise. However, mobility drives development. So it's important that we invest in planning for mobility and having modern systems of being able to capture information on mobility. That also very key in terms of mobility and therefore migration of persons from one county to the other, from rural areas into our cities becomes important. Thirdly, working in an integrated manner is so important that stakeholders need to work together. The national government, the county governments, professionals of various lines need to work together, because this is the only way we can enhance the delivery of services. Then the fourth item is migration data is important for planning, and they need to have various ways of collecting this data on a regular basis. We know that at the moment, the only comprehensive migration data we collect is every 10 years during the census. Now, certainly for sure, data 10 years old is not very useful. So it's important that we also invest in being able to collect this data in a more regular manner than just the 10 years that we have at the moment. And then lastly, balancing development, especially in terms of rural areas, so as to reduce the smuggling and trafficking in persons. We see instances where children, girls, boys indeed, being trafficked from parts of the world, maybe to the coast for other issues and whatever. This is an important thing so that we have balanced development in the counties. Thank you very much. God bless.
Thank you, Engineer. Thank you very much for also that key highlights from your session, which you chaired, and that migration and on mobility and internal migration. Thank you very much. I think the issue of migration, issue of that, I think it's from the other key, from the other chair, the other previous chairs who spoke. They also said about the issue of data and migration. So I think very important points. Thank you very much. So I think now we will go to the last to the chair and the session on population and environment. And here I invite Dr. Charles Lange just also to give us the key highlights from the session. Dr. Charles. Dr. Charles, are you there? Dr. Lange? Okay, I think seems we can't identify Dr. Lange, or he's not there. I think he dropped off. Dr. Lange, any presenter from that session or any panelist or participant who can just give us the key highlights of that session? I think we had our rapporteur there. Yeah. The team, if you are a participant of that session, you can just give us what transpired there. Or the rapporteur for that session. Now we have Francis who was there. From outside. But I can give this opportunity to Professor Sosten Chata from Malawi. I also participated in his presentation. Professor, are you there?
Yes, I'm here.
Yeah, Professor. And just let's just say something on what transpired in that session. And I like your presentation. I saw it briefly.
Yes, there was excellent synergy between the three presentations, highlighting the built environment where most people are in unplanned settlements and having high risk to climate change impacts. There was it was also mentioned by the presenters that there's need for partnerships because issues of population and environment affect so many sectors, and they needed to work together. I think one observation from the participants was that the three presentations had not emphasized the issue of health. And so I think that's a very critical point, and perhaps we should have talked about COVID-19, which actually has its origin from unsustainable use of environment and natural resources, and also the spread itself is actually linked to human interaction with one another and the environment. So I thought that was a very critical point. And whether you use the PHE, population health and environment approach, or you use the eco-health approach, you actually see that population and the health and environment do interact. And perhaps when you draw causal loop diagrams, these linkages can be well manifested. Thank you very much, Chair.
Thank you, Professor. Thank you very much. Anything else to see if we have another panelist? Dr. John, you are there? You want to say something? Dr. John Kyoko? Or Mr. James Otieno? Because you can't allocate Dr. Charles, I think you broke off. Okay, so dear delegates and moderators and panelists, I think that has been a very, very, very successful session. We were recording these sessions. So, and there are rapporteurs who are also going to write a report on this. The discussions of these panels discussions will go into our final report of the conference. It also will enrich our population policy, and then we'll share the report of each sessions with the respective chairs before we put in our main report. So for me, I want to take this opportunity to thank the delegates, the panelists, the moderators for that very successful session. I know we had challenge with the technology in terms of transitioning from one link to the other. I think we managed it. I think the participation really has been very. It's 2 o'clock, and I can see still we have quite a number of people still participating. I just want to give you again a heads up on tomorrow's session. Tomorrow again will be another very, very heavy day where we're going to have again similar arrangement in terms of sessions. We're going to have in the first morning we're going to have apart from the opening from 8 to 8:30 when we're going to join, when we're going to link, we're going to use the same link. Yeah. We're going to use the same link. Yes. That we will start at 8 to 8:30. That's what we're going to join, and then we'll be given a bit of guidance and direction on how we will be going to have the groups. But directly we'll go to our groups after the MC remarks. And the groups tomorrow will be on issues of the sub-themes. It's going to be again on age structure. Another sub-theme will be on family planning, best buy for Kenyan development agenda. We're going to look at issues of, another theme will be mobility and mortality among adolescents and young people. We're going to look at issues of international migration and issues of human settlement. Our chair for the first session on theme on number 1 or 1.2, that's going to be Dr. Adimora Oligite, who is the representative of UNFPA in Kenya. On theme number 2.2, which is on fertility, family planning, best buy for Kenya development agenda, we're going to have Professor Richard Muga, who is the CEC for Homa Bay. On theme number 3.2, mobility and mortality among adolescents and young people, we're going to have, the chair is going to be Dr. Sheila Macharia. So we're going to have really quite a number of people here. You can see also the panelists there. On theme number 4.2, international migration, we're going to have the chair as Charles M. Munyao, who is the Deputy Director of Migration Secretary. And then also on theme 5.2, we're going to have human settlement. The chair is going to be Professor Edward Mburu, who is the Professor of Sociology, Faculty of Arts, University of Nairobi. So that will be the first session, and that will be given to the same. We're going to have the same arrangement. We're going to have 5 groups. Then we'll have this one as the main hall, and then we'll again have another 4 halls. The same day we have just done right now. And then that will take us from 8:30 to 10 o'clock, and then we'll have from 10 to 10:10. We're going to have a break, and then we're going to proceed and have again next session, which is going to be from 10:10 to 11:40 a.m. And that's again, we're going to have issues of, again, vulnerable population, offices, the elderly, people with disability, and displaced persons. And here, we're going to have the chair is going to be Nicholas Gitua, who is the Director of Planning, State Department of Social Protection. On theme 2.3, which is going to be marriage, child marriage in Kenya, we're going to have Professor Onyango Ouma, who is the Director Institute of Anthropology, Gender and Africa Studies. And this is theme number 2, that's on fertility again. And then on theme number 3, which is going to be again sub-theme of adult morbidity and mortality, we're going to have the pleasure to host the cabinet, the Chief Administrative Secretary, Dr. Mas Mangagi of Ministry of Health, who is going to chair that session. And also we're going to have quite a number of panelists there. And then on migration, mobility, and urbanization, we're going to have the sub-theme urbanization, and the chair will be Hon Alex Wiru, who is the Cabinet Secretary, Ministry of Lands and Physical Planning. Also, we have quite a number of panelists there. And then on theme 6.1, we're going to have data and research. We're going to have the chair, Waweru Kamau, who is the Director of Social and Governance, Director of the State Department of Planning. And we're also having quite a good number of panelists in that session. So lastly, we're going to have the session that is from 11:40 to 1:10. That's around 1:10 p.m. We're going to have, again, issues on theme number 5, population, human settlement, environment, but sub-theme 5.3, we're going to have hazard and risk response. The chair here is going to be Duncan Ochieng, Dr. Duncan Ochieng, who is the Director of National Disaster Management Unit. And then we're also going to have theme number 6, which is data innovation and research, sub-theme 6.2, innovations and data availability. We're going to have the chair is going to be Alois Ratemo, who is the Director of Monitoring, Evaluation, Director of State Department for Planning. And then theme number 7, education and training, we're going to have sub-theme number 7.1, the role of education and training, harnessing the demographic dividend. And we're going to have the chair is going to be Rev. Canon Chris Kinyandui, who is the chair and who is the chair of the National Council of Churches of Kenya, NCC Kenya. Then lastly, we're going to have sub-theme 8.1 toward the sustainability, public-private sector, and resource mobilization for the population program. And we're going to have chair is going to be Engineer Mark Nyamita. Engineer Mark Nyamita is the MP for Ruri, and is the vice chairperson for Parliamentary Network and Population Development. We work with him very closely. So, yeah, delegates, that's how our program tomorrow will look like. So, with this, I want to take this opportunity really to thank you, and we will apologize for any hitches and any challenges that we had this morning. For that, I want to say thank you very much. I want to invite the overall ANC again to give us, I think, a word of prayer or guide us. I think that is how it's going to be the session. Unless there is any question, we can allow any concern from the delegates. You just raise your hand. But tomorrow again will be another busy day. I think we all have those 3 sessions of the thematic area sub-themes. I will really invite you to join us. Yes, using the same link. If you have any challenge, kindly write to us or reach our ICT team and our population team here, and we're ready to support you. Thank you very much. That's okay. So I think I'm told we can close it. I don't know. Is there anyone who can pray for us? We can ask Sam Lobanga to pray for us, please, Sam. And we want to wish you good afternoon. Thank you very much. God bless you.
Thank you, DG, and thank you, delegates. Let's bow for a word of prayer. Our loving Father, we are glad and thankful that you have allowed us to see the light of the day. We've been preparing to have this session happen in good order. Indeed, the conference is here. And even as we continue to engage, Lord, discussing concerning your people, our prayer is that you may allow that wisdom and that knowledge, that understanding we require to come through for us. We ask for your spirit, you to guide us. We ask for your power and your grace. And allow, Lord, even that the work you did on the cross not going vain, but each and every time remind us of the love you have for us. For this, Lord, we commit the rest of the program ahead of us, and we continue to keep even our presenters and any other persons to join us for subsequent meetings. In Jesus' name we pray. Amen. Thank you.
wanafurahi, vijana wetu wana ajira, waweza pia kujiajiri. Mimi naomba amani Kenya ili